The Affordable Act of 2010, also known as the Obamacare, was the most monumental change in the United States healthcare policy since the passage of the Medicaid and Medicare in 1965. Since its enactment, numerous claims have been made on both sides of the aisle regarding the Obamacare success or failure. These views often colored by political persuasion. The Affordable Care Act had three primary goals: increasing the number of insured, improving the quality of care, and reducing the cost of health care. One point often lost in the discussion is the distinction between affordability and access. Healthcare is a financial mechanism for paying for health care, while accessing refers to the process of actually obtaining that health care. The Affordable Care Act has widened the gap between providing patients the mechanism of paying for health care and actually receiving it. The Affordable Act is applauded for increasing the numbers of insured quite approximately as they have had occurred for over 20 million people. Less frequently mentioned are the 6 million who had lost their insurance. Further, in terms of how health care is being provided, the expansion was based on Medicaid expansion with an increase of 13 million. Consequently, the Affordable Care Act hasn't worked well for the working and middle class who receive much less support, particularly those who earn more than 400% of the federal poverty level, who constitute 40% of the population and don't receive any help. As a result, exchange enrollment has been a disappointment, and the percentage of workers obtaining their health benefits from their employers have decreased steadily. Access to health care has been uneven, with those on Medicare hampered by narrow network, while those on the exchange or getting employment benefit has faced higher out-of-pocket costs. The second category, relating to cost containment, President Obama claimed that the Affordable Care Act provided significant cost containment, and that cost would have been even much higher if the Affordable Care Act was not enacted. Further, he attributed cost reduction generally to the Affordable Care Act, not taking into account factors such as recession, increased out-of-pocket cost, increased drug price, and reduced costs by insurers. The final goal was improvement in quality. The effort to improve quality has led to the creation of dozens of new agencies boards, commissions, and other government entities. In turn, practice management and regulatory towards complied costs has increased. Structurally, solo and independent practice, which lacks the capabilities to manage these new regulators' demands, has declined. Health employment, which is associated with increased costs, have been soaring. Despite a focus on preventive services in the management of chronic diseases, only 3% of healthcare expenditures have been spent on preventive services, whilst the cost of managing chronic diseases continues to escalate. What did the Affordable Care Act do for insurance expansion? The Affordable Care Act expanded insurance coverage in two principal ways. First, it created health insurance marketplace at the state level on the premises of competition and choice. Individuals could compare and similar coverage options and choose among competing plans. The health law also provided low-income individuals and households up to 400% of the federal poverty line, which subsidized to help them purchase insurance. Secondly, the Obamacare of the Affordable Care Act expanded eligibility for the Medicaid program to individuals and families with incomes up to 138% of the federal poverty line, about $35,000 for a family of four. Since the law implemented in 2010, the number of uninsured people in the country has fallen by about 20 million. The challenge to the Affordable Care Act. The law has endured numerous legislative challenges following its passage. The House of Representatives advanced over 50 bills to repeal the Affordable Care Act in whole or in part, with the Senate voting on a subset of them. These started out as a large symbolic, a presidential veto which virtually guaranteed while President Obama was in office, but began to pose an existence threat to the Affordable Care Act under a unified Republican government that held power during the first 2 years of the Trump administration. The narrow 49 to 51 votes defeat of the last permanent repeal effort in the summer of 2017 illustrated the truant's tendencies ground upon which the law sets in the previous Congress. However, it survived. Its survival was also a testimony to its legislative durability. The political challenge of withdrawing health benefits started across different constituents and had been further insurmountable despite lukewarm public opinion on the law. Looking forward to 2019 and beyond, the prospect for near-term repeal has diminished with Democrats taking control of the House of Representatives. But the Affordable Care Act has not receded from the public debate. On the contrary, health care rank among voters' most important issues in the 2018 midterm. The administration and new Congress will need to decide whether to leave the law alone or modify it. Additionally, attempted to weaken the law through regulatory channels will be subject to increased scrutiny now that Democrats have more congressional oversight. Perhaps more fundamental for the future direction of health policies, public opinion on the role of government in healthcare is evolving. In 2013, 42% of Americans believe that it is the responsibility of the government to ensure that all Americans have coverage. That number rose to 60% in 2017. Support for Medicare for All proposal had also climbed in the recent survey. Though these opinion has been multiple to follow-up questions. These public opinion trends suggest that a growing share of Americans may be receptive to proposals that move the Affordable Care in a more progressive direction. Where does the Affordable Care Act need to be mended? The law needed to strengthen the language that empowered the Affordable Care Act to refuse coverage from new technology. The language was weak, and it allowed the marketers of costly new drugs and devices to obtain Medicare coverage for their product, even after existing products was equally effective and cheaper. The recommendation to refuse payment for technologies that was both costly and ineffective seems straightforward, but efforts to include such effectiveness as a criteria for coverage in the Affordable Care Act led to panic and an outcry about health care rationale for the public. The Affordable Care Act failed to address the need for price transparency for patients. Physicians and hospitals are not required to post the price they charge for the office visits or elective procedure, making it extremely time-consuming and difficult for patients to compare the potential price of seeking care from different physicians and hospitals. In conclusion, it has been a struggle to explain many important aspects of the Affordable Care Act. in the United States health care to anyone. We quickly realized that even these well-informed individuals was facing significant difficulties understanding more than 1,000 pages of legislation. Different things were not really clear about the Affordable Care Act. But what was clear was the physicians who had primary authorization for prescribing and delivering treatment, as well as the best ability to identify cost-effective care, they had a big chunk of the plan. The federal government can do only so much to provide subsidies and regulations to increase access to health insurance. The future success of Obamacare or the Affordable Care Act depends on the doctors willing to take the lead in identifying high quality, cost effective health care for the people.